Great, thank you, Ashley. And hi, everybody, and welcome to this year's training course. It's great to see some of you and see all of you on here. My name is Catherine Guadizzi. I'm a senior epidemiologist in HRSA's Maternal and Child Health Bureau, and I oversee the training course on behalf of the Bureau. So today I'm going to provide an introduction to the training course, including some information about the Bureau as well as an overview of some resources. I'm going to go ahead and share my screen. I'm going to turn my video off to make it easier since I have multiple screens going. If you have any questions at all during the presentation, please feel free to put them in the chat. I won't be monitoring it during the presentation, but we can certainly get to those at the end and have time for any questions you might have there. I'll share my screen. All right. Can you see my slides?
Yes.
Great, thank you. All right. So first, what I'm going to do is provide some background on the course, including its purpose and history, and then I'll share some general descriptions of the 2021 class, or all of you, who you all are, what states and jurisdictions you represent, and then I'm going to discuss what to expect from this year's course. That will be our second virtual training course, and hopefully our last for a little while. I'm also going to provide information on additional training and data resources, including web links that may be helpful to you in your current work. And I'll close with a brief overview of HRSA's Maternal and Child Health Bureau and selected initiatives that we have ongoing in the Bureau. And you all are going to receive a copy of these slides. So for any of the web links and things that I provide, you don't need to jot them down quickly. You'll be able to click on them when you get a copy of these slides. So beginning with the Title V block grants, which were enacted in 1935, they were first created to develop service systems in our nation's communities to meet critical challenges in maternal and child health. And while the main function of maternal and child health personnel in state and local health agencies had been providing direct health services to their MCH populations, there was a shift in the 1980s to implement the core functions of public health, which are assessment, policy development, and assurance. The Omnibus Budget Reconciliation Act of '89 further mandated new data analysis and reporting requirements for MCH block grant recipients and state health agencies. And in order to accomplish these functions, state and local health departments recognized the need for epidemiological expertise for providing tools for collecting, analyzing, and interpreting health data. And many states realized that they lacked such expertise and approached HRSA and the CDC requesting epidemiologic support and training. So in response, the Maternal and Child Health Bureau has been engaged in establishing several programs in order to build epidemiologic capacity at the state and local levels. In 1987, the Maternal and Child Health Epidemiology Program was established jointly with CDC's Pregnancy and Infant Health Branch within the Division of Reproductive Health and the Maternal and Child Health Bureau. And they work together to enhance the capacity of state maternal and child health programs to carry on public health surveillance and database decision-making functions effectively. Under this program, CDC epidemiologists are assigned to state health agencies to help develop and enhance MCH epidemiologic capacity, and they're often funded by block grant dollars. More than 40 MCH epidemiologists have been assigned to build capacity and applied research to state health departments and other public health agencies and organizations. Now, the Bureau also provides the State Systems Development Initiative, or SSDI, to provide funding for enhancing and expanding data capacity used flexibly to support new data systems, linkages, analytics staff, and the needs assessment. This program complements the Title V block grant program by improving availability, timeliness, and quality of maternal and child health data in the 59 states and jurisdictions. Now, we also started building the future workforce through funding to schools of public health for centers of excellence in MCH education, science, and practice. These programs support graduation education at the master's and doctoral levels and emphasize MCH leadership training, applied research, and technical assistance to community states and regions. There are currently 13 schools funded. We also added a doctoral training grant to support PhD student dissertations using state and local data. The CDC and the CSTE, or the Council of State and Territorial Epidemiologists, sponsor 2-year applied fellowships for recent graduates in applied epidemiology. This provides high-quality training experience and helps to secure long-term career placement at the state or local level. Annual meetings and periodic webinars among MCH professionals are also held to exchange information and to offer training workshops. The annual MCH Epi Conference, which is now merged with CityMatch and generally conducted biannually, although it's a little different right now given COVID, and the next meeting will be this winter in December. And this allows for peer exchange, networking, and continuing education. And finally, the training course, the one that you all are participating now. This is something that MCHB started sponsoring in 2002, and it's unique in that it develops and trains existing workforce within state and local health agencies in broad-based fundamentals, such as needs assessment, epi and statistics, program evaluation, data presentation and translation, and not targeted topics offered prior to AMCHIP or CDC conferences, such as small area analysis or GIS. Now, the CSTE conducts periodic epidemiology capacity assessments to monitor the strength and function of applied epi capacity in state and territorial health departments. So typically, they've provided limited information on the capacity within specific program areas such as MCH. So they've added supplemental modules to assess MCH programs. Now, these data show that MCH epi capacity has really grown over the last 2 decades, and hopefully, actually more than 2 decades, and hopefully that part of that is because of some of the efforts that I mentioned earlier. Now, what you'll see here in the blue bar, so these are those with greater than or equal to 50% capacity for MCH epi and surveillance. And you'll see in this time period, it increased from 43 to 73% from 2004 to 2013. States with minimal or no capacity decreased from 25% to just 6%. The most recent data that we have available is from the 2017 capacity assessment, which showed even more improvement. Between 2009 and 2013, states and territories reported increases in the percentage of MCH epidemiology leaders with administrative and scientific authority, an increase in the percentage of MCH epidemiologists with master's degrees, the increase in the percentage with access to family planning, hospital discharge data, emergency department data, and WIRE-DS data, and also an increase in the number of peer-reviewed publications, abstracts, and reports. Between 2013 and 2017, the percentage of states with an MCH program lead increased from 78% to 92%. Now, earlier this year, the CSTE conducted the 2021 epidemiology capacity assessment. And while we don't have results yet, this is expected to provide important information about the current capacity of epidemiology programs in the state health departments. So there are some areas for improvement that are noted. First, only 37% of states had almost full or full MCH epidemiology and surveillance capacity, and that was based on those older data. Additionally, only a minority of jurisdictions, the maternal and child health epidemiologists, participate almost fully in policy development and have access to important data sets. Only 46% routinely perform statistical comparison tests, and only 27% routinely conducted multivariable analysis. And at the time of those assessments, the most pressing need was additional staff and training of existing staff. In 2017, state epidemiologists acknowledged needing an additional 122 MCH epidemiologists, and this was tied for the 3rd highest area, needing more epidemiologists to reach the ideal number. Now shifting to the course purpose and structure. So this year we're hosting the basic and intermediate course. And really the purpose of this course is to strengthen the epidemiologic skills of existing and state and county data analysts to inform and improve programs. And in this certain year of the course on the basic side, the focus is on an introduction to multivariable analysis with additional lectures on perinatal periods of risk and measures of impact, to name a few. In reality, we are shifting away from descriptive analyses and moving into more of the regression and multivariable analysis. And while these methods are important for program evaluation, identifying the why and how of the patterns we see in morbidity and mortality, that tells us what we need to address in terms of interventions. Now, the training course is an intensive program. It combines lectures, discussion, hands-on exercises, and opportunities for individualized technical assistance. So now I want to introduce to you the course faculty. So as you'll see on the screen, our four key course faculty are here, starting with Dr. Bill Sappenfield, who will be presenting this year on needs assessment, Dr. Pat Ocampo, who will be talking about program evaluation and social determinants of health, Dr. Michael Kramer, who will be talking about relative absolute measures of impact, as well as multivariable analysis approaches, and Dr. Mike Smith, who's our faculty coordinator, who this year will be presenting on data communication to non-academic audiences. I want to just let you know that these faculty are incredible. They have a wealth of experience. Many of them, if not all, have won teaching and mentoring awards for advancing knowledge or have earned early career awards, and you're really going to learn so much from them. And I really strongly encourage you to reach out to the faculty during these next several weeks. As Ashley mentioned, you're going to get intro videos on all of the faculty. I encourage you to watch these and reach out to even just discuss career development if that's of interest to you. This year, thanks to the virtual format, we're also very fortunate to have additional faculty join us. We have Carol Gilbert from CityMatch and also Dr. Ashley Harai from Hershey's Maternal and Child Health Bureau, and they'll be joining us to discuss perinatal periods of risk, as well as analytic approaches for performance measurement. I'll also mention, although I don't have pictures here, at the end of the course, we have very special guests coming to join us for the social determinants of health panel on the very last day. It's going to be a Friday at the end of the day. I'm going to tell you all now to plan to be there for the whole thing if you can, because we have some great people from the field joining us to have a really robust discussion. And finally, our partners at CityMatch, Ashley Sutphin, who's been working diligently to make sure everything runs smoothly. And she's been doing a great job. I'm sure that you all have been in touch with her. She's been focusing on our project management and coordination, course planning and schedule, logistics and communications, along with other colleagues at CityMatch, including those that she mentioned that are with us here today. So in terms of course preparation, both the webinar that I'm giving you today, as well as the webinar that Dr. Smith will be presenting on the statistical and epidemiologic framework next week, these lay the groundwork for what will be covered in the course. There are also reading materials and exercises to help you prepare and inform some discussion that will be located on with all of the materials, I believe, in the team site, if not in the Google site, but Ashley will give you more information about that. And these materials are electronic. Also, I just want to mention that all of the materials from previous courses are available online if you're interested in seeing some other topic areas that perhaps aren't going to be covered in the course this year. And so this is just an overview of our 3-week virtual training in terms of the topic areas that we'll be focused on during the weeks. So as you've probably already looked at the schedule, we'll be meeting 3 days a week, and these are the topics that will be presented within a 2 to 2.5 hour time frame. There will also be some homework materials. You can schedule virtual office hours, and then finally the social determinants of health panel that I mentioned that will be held on the last day. We also have post-course training webinars, and I've listed here a sample of topics that we have had in the past. The top 2 were last year's post-training course webinars, and we will reach out with input from you all and what topic areas you might want to have covered. Those usually happen within a few months after the end of the training. As always, we provide ongoing technical assistance. If you want to follow up with any faculty or any of your colleagues here in the cohort, if you have questions about a project, you can feel free to reach out for any input that you may want. And then, as Ashley mentioned, we do a 1-year evaluation to get a sense from you on kind of where you are in your employment, whether or not you sought technical assistance, any skills that you acquired or strengthened. We ask that you self-identify some of those and examples of projects or products that were enhanced as a result of what you learned in the training course. We apply CQI to the course, and your feedback is really important. We have evaluations after every session and at the end of the course. And really, we take all of that feedback and incorporate it into our future. There's some examples of what we learned from evaluations to improve the course. For example, we learned that when the training was more intermediate, some people would be bored and some would be lost. So targeting the skill level made the course more effective. We started moving more people from basic to intermediate and then intermediate to advanced. In the past, participants have asked for advanced sign up for individual technical assistance so we can match folks with an appropriate person and organize similar requests so you can all benefit from the discussion. There's been a request for more networking opportunities, and while this is not able to happen this year like it has in the past, being virtual, please reach out to your peers and faculty virtually. I know I've said this multiple times already, just in the first 20 minutes that we've been talking, but I strongly encourage you to do that. Also, career mentoring has been a request in the last couple of years, so feel free to reach out about that as well. Ashley and colleagues have put together a photo roster, and that was a recent request in some of the past years, and it's really extremely helpful to get to know each other. We know that training can be overwhelming, so we strive to cover fewer topics in greater depth. Previously, we may have been trying to cover too much, so we've incorporated that feedback. And so while the course may not seem to cover every topic that you may have been anticipating, we will certainly provide other resources to get you some of that content as available. So what I've provided here are examples of impact. So in the one-year follow-up, we'll ask you for some of these statements, and these are some quotes of what some former trainees have described and hopefully what you can look forward to learning and incorporating as well. I'm not going to go through and read them, but these are direct examples of what prior trainees have said following the course and how it has helped them in their work. Now, reaching out to faculty and meeting during possible office hours can really help you to think about current projects and how you might be able to apply course materials and hopefully plant a seed for continued integration back into your jobs. So I'm going to pause, and I've scattered some photos throughout to bring you on my COVID journey with my family, just to give everybody a little break. This picture may look familiar to those of you who have children that were learning at home. These are my 3 kids very early on in the pandemic when they actually looked like they were interested in learning at home. This quickly shifted when we learned that the pandemic was going to keep them home for more than a year. Anyway, now I'm going to shift back to you. So we had over 200 applicants this year. I have to say it was probably one of the highest numbers of applicants we've had in the past. So you're a very select group. Approximately 24% were accepted, or 1 in 4. So really congratulations to all of you for standing out and becoming part of this cohort. This year, we have 49 trainees representing 36 states and territories. We have 31 in state or territorial health departments, 11 in city or county health departments, 5 in tribal epicenters, and 2 in other settings. I've also provided some other statistics here, just on some demographics based on self-reported information in the applications that you can see here. So you are all located all across the country, coast to coast, as far as Hawaii. And we have 10 states with multiple representatives, as many as 4 in Ohio, 3 in Arizona, as well as 3 in California. Also, as indicated by the hash lines, we have 5 states that have trainees at both state and local levels or tribal levels, which we really like to see to foster that collaboration and synergy at state and local levels. For those of you where there are multiple participants in a given state, maybe look each other up. If you don't know each other already, that might be a great collaboration for you to reach out to your state or local partners. It's really important to get the most from this course. I know it's difficult in a virtual setting. We all have other things going on in the background or at home. I want to recommend that you attend as much of the webinars as possible. They will be recorded. So if you happen to miss a piece of one, you can certainly look back at the recording. But the advantage of being live and in person is that you can ask questions and be part of a discussion and engage with the faculty, which I think is a really unique opportunity. Really use the opportunity to focus, turn off your email if you can, shut down all distractions so that you can really focus. I know that we all have become a pro at this over the last year, and it can be difficult to sit through some of these presentations, but we've tried to create the schedule in a way that allows for, not that you're sitting for 3 hours long, that you're just sitting for a little bit of time. Network with one another, share tricks and tools. There will be a lot of material. Some may be a stretch for some of you, but many references to continue learning. Ask questions anytime. We're happy to answer them, whether it's during the presentation, after, or even in the future. And seek technical assistance during and after the course. This is really a great time when many of our faculty who are normally engaged in teaching at their universities are available in the summer during this course to help you and address some of your questions that you're experiencing in your work. So now we're going to do a poll, and this poll we're going to send to you all, and of the topics that we've sort of pre-chosen based on your applications and what you stated you'd be interested in knowing, what topic areas from this selection would you be interested in discussing with the faculty? So you should see on your screen, we've got 6 possible topic areas. Of course, there may be others that you'd be interested in, but if you could just select those from this list for now, that would be very helpful to us.
And we will have sessions on some of these topics, but what we're asking about here is what would you be interested in discussing in more of a virtual roundtable format, so more discussion based.
Thank you, Mike.
Okay. Final chance before I end the poll. Okay. Perfect.
Great. So thanks you all for participating in the poll. I see that the winner of the 6 topics seems to be multivariable regression, which is great because I know we have a session devoted to this. So perhaps that might lead to further discussion in a separate sort of discussion-based meeting. We also have social determinants of health. You've come to the right place. We have several opportunities already on the agenda around social determinants of health from Dr. Pat Ocampo, as well as during the panel that we talked about. And perhaps we can also set up some individual discussion around that. And it seems like outcome evaluation was another area of interest. So thank you everybody for this. And of course, I encourage you, if there are other topics that you might be interested in hearing more about, please let us know. You can either put it in the chat or reach out to us individually. So now I'm going to shift into some additional training and data resources. And now there's a lot of information here. And as I mentioned, you're going to get a copy of these slides, so you'll be able to see this and click on some of these links directly. So first, I'm going to start with some of the HRSA's Maternal and Child Health Bureau training resources. So historically, we've offered Data Speak webinars, which feature topics related to maternal and child health data. And it's been a few years since we've hosted these, and I'm not certain if they will be coming back soon, but we certainly can keep folks posted. I've included 2 examples here of some of the last Data Speak webinars that we did, one on our National Survey of Children's Health and another focused around maternal health. We also have the Enrich webinars. These feature topics related to MCH research and methods. We've had several of those this past year. I've included examples of the most recent ones. You'll see the first 3 were focused on COVID-19, no surprise. And so I encourage you to sign up to get information about these webinars as well. There are also listservs for Epi and research, and I've provided the web link at the bottom. Again, when you get a copy of these slides, you can click on that and it will give you more information about how you can sign up to be on these listservs or hear more about these webinars as they're happening. There's also the MCH Navigator, which is run by HRSA's Division of Maternal and Child Health Workforce. development, and this provides bundles of training resources compiled from various sources, including epidemiology. Some of our course material is archived on here and includes additional topics we aren't covering this year, such as multi-level longitudinal modeling and missing data analysis. And this is just an example of what the website looks like. Here's some additional training resources. CDC MCH Epi has listservs and grand rounds. I've put the addresses here if you want to get on these listservs if you're not receiving these emails already. The second bullet here you'll see is the HRSA MCH Epi listserv, and there is some cross-listing in some of these listservs. So if you're on both of them, you might get similar postings, but there are also some unique ones as well. We also have AMCHIP. So AMCHIP provides and organizes technical assistance on several epidemiology and data related issues. Examples of their so I've listed here the link for that. Can you all still hear me?
Yes.
Yes.
My VPN just decided to shut off right in the middle, so I'm just reconnecting and it might just pause me for 1 second, so I apologize. All right, can you still hear me?
Yes.
The City Match, of course, specializes in local maternal and child health. They have wonderful trainings on PPOR, which you'll also hear about during the training course this year. And they also take here, I'm sure you're already familiar with a lot of these data resources, but hopefully you'll see something new here. I've listed some links for Healthy People, county health rankings and roadmaps, the Title V information system, MCH Data Connect, Peristats, and then CDC's nutrition, physical activity, and obesity data. Continuing on my COVID journey, I live in the great state of North Carolina, and we did a lot of family road trips this year. And the beautiful thing about North Carolina is that you can go to the mountains and the beach from where I live in just a matter of hours. And in fact, I would venture to guess that Mike Smith's house is probably not too far away from this mountain range in North Carolina. And this was our first and only glimpse of snow this entire year in North Carolina. And I put a second picture to show you the beautiful mountains of North Carolina without snow, but essentially in the clouds. All right, so moving into administrative data resources, many of these data resources you can obtain directly from your state offices, except for the census data. And these include complete population records that are even more valuable than links. Many of you probably already work with many, if not all, of these data sources, but I just wanted to acknowledge that these are out there. We also have several survey data resources. You'll see I've indicated here CRAMS, the YRBS, the BRFSS, the National Immunization Survey, and the National Survey of Children's Health. So the National Survey of Children's Health is housed within the HRSA's Maternal and Child Health Bureau. It is sponsored by us, but it's conducted by the U.S. Census Bureau. We also have co-sponsorship from other federal entities like CDC, the USDA, and the EPA, depending on the questions that are included in the survey in a given year. This survey provides national and state level estimates of key measures of child health and well-being. It's quite unique in that it provides these estimates of children's health from anything from physical, behavioral, emotional, contextual. It provides information on healthcare access, as well as information for children with special healthcare needs. It is conducted annually, which is new since 2016. It's cross-sectional. It's address-based survey that collects information via the web and or paper and pencil questionnaires. It is designed to collect information on children ages 0 to 17. It includes not only physical and mental health, as I mentioned before, but also related healthcare, family, community level factors that can influence health. As I mentioned before, it's unique in that you not only can get national estimates, but you can also get state level estimates. Data are collected for approximately 9 months out of the year and then released the following October. For those of you who are used to working with survey data, you will know that this is practically lightning speed. This moves pretty quickly. All data are collected from parents or guardians in English and in Spanish. And currently the most current data available are from 2019. And we also, on our website, which I'll show you in a second, we have several data briefs from 2018. So we keep this kind of current from the previous year to the extent that we can. This is what our website looked like right now. I provide the link here. This is sort of the forward page to the HRSA website. It talks to you about how you can access 2019 data, and you'll see that we have several data briefs here for 2017 and 2018. We often combine multiple years of data for measures that were consistent across the years for some of our data briefs, especially those that might have small numbers where we need to combine multiple years together. Now the Data Resource Center, I provided that link here. The Data Resource Center advances the use of the National Survey of Children's Health. It takes the results from the survey and makes them easily accessible to parents, researchers, community health providers, and anyone interested in maternal and child health. Data on this site are for the nation in each of the 50 states plus DC. State and national data can be further refined to assess differences by a whole host of variables such as race, ethnicity, income, type of health insurance, and a variety of other important health characteristics. So you can go to the link that's on here. There's an interactive data query. You can choose which years you want to look at the data. You can select if you want to look at a specific state or region, and then you can select your measure. It allows for the ability, and I'll show you this in a minute, to compare data across states. You compare data across multiple measures. You compare states using single measure maps. We also have maps for our national performance measures and our national outcome measures, and those can be used to compare state estimates and national estimates. So if you go to the web link, this is what it looks like. You can click, and it's sort of changed over time. You can click on that interactive data query on the left-hand side, and then it brings you to something that can look like this. So here I've selected one of our national performance measures focused around the percent of children with special health care needs who have a medical home. I picked it for 2018 to 2019, so that's 2 years of survey data. I put national, not a specific state, and it gives you the estimate along with the confidence interval. Now, as I mentioned, you can present all of the national performance measures across states to do a comparison. So it provides this table that sort of ranks them by color from low to high performance. You can actually sort these columns from lowest to highest or highest to lowest, however you want to look at it, so you can see where your state falls with respect to a whole variety of indicators. And like I said, on this map, these are the national performance measures. You can also generate a map where you can see what these measures look like nationally. The data here are for the percent of women with a preventive medical visit in the past year. These are the data from the 2019 behavioral risk factor surveillance system. And you can use this to kind of see how your state compares. So all of this is available on the DRC website. If you haven't used it before, I encourage you to check it out. You can explore, as I mentioned, the National Survey of Children's Health, but also some of the national performance and national outcome measures and the associated national data sets that go along with it. So now we have another poll, except this poll is a little bit different. We're not going to pop up the poll on your screen. We're curious to know which data sets you analyze in your current position. So if you could put that in the chat right now, we will kind of monitor that and just get a sense of what data everybody is using. So please go ahead and enter that in the chat. Great, looks like a lot of similar data sets being used across folks, which is great. Great, thank you everybody for answering those. And feel free to keep putting in some information. So now I'm going to move into an overview of HRSA Maternal and Child Health Bureau and select initiatives. And many of you may be familiar with some of these already. So I'm going to tell you a little bit more about the Bureau and office I work in. Sometimes people think the Maternal and Child Health Bureau is part of CDC, but it's not. We are totally different agencies. The Maternal and Child Health Bureau is part of HRSA, which is also known as the Access Agency. And one of our largest programs is focused around community health centers. As you'll see here on the screen, the Maternal and Child Health Bureau is one of 5 bureaus within HRSA, and our mission is to improve the health of America's mothers, children, and families. Our Bureau's vision is an America where all children and families are healthy and thriving and have a fair shot at reaching their fullest potential. And to achieve this vision, we rely upon evidence-based strategies to implement our programs and monitor their effectiveness through data-driven means. There are approximately 250 employees within the Maternal and Child Health Bureau. We have approximately $1.4 billion in funding. Primarily, MCHB supports states and jurisdictions through the Title V Maternal and Child Health Block Grant, which is complemented by the Bureau's portfolio of discretionary and appropriated grant programs. 85% of funding goes to the Title V Block Grant, so it truly is the largest source of broad-based funding. And there's federal state partnership to identify and flexibly address key national and state health, maternal and child health priorities. And it's the largest public health investment devoted to overall MCH. So I've provided here sort of our organizational chart. The Bureau Associate Administrator is Dr. Michael Rowland, who is a pediatrician by training, and he's been with the Bureau for a few years now. You'll see the Office of Epidemiology and Research, which is the office that I sit in, that's identified here with the blue circle. That is where the training course is based out of, as well as a national survey of children's health and all of our sort of epidemiology and data focused efforts. The Office of Epidemiology and Research is led by Dr. Michael Kogan. I've listed here some of our office goals around building data research and analytic capacity. And that's what this training course really is hoping to do, to strengthen, develop the present and future workforce in MCH epidemiology. We also conduct, support, and disseminate research and data to strengthen the evidence base in MCH. So we have an intramural epidemiology program where many of our staff are involved in doing our own analyses, both with our National Survey of Children's Health, as well as other national and state level data. We also have an extramural research program where we support research in other areas, whether it be at universities and states or local levels. We also provide analytic support to inform the planning and evaluation of Bureau programs and initiatives. So we team up with other divisions within the Bureau to help support their work. This is a list of some of our programs initiatives. This is not a comprehensive list, but I've identified some of the key areas that we focus on. As you all are familiar with the Title V Block Grant, we have the Home Visiting Program, the Healthy Start Program. And in recent time, we've really strengthened our maternal health portfolio. I've listed here 5 of our key programs that fall within this portfolio, but it is definitely larger than this list, but these are the ones I'm just going to sort of touch upon today, especially given the current administration's interest in maternal health. This area has really grown over the last several years. So in terms of the Title V Maternal and Child Health Services Program, in 1935, the president signed into law new legislation to promote and improve maternal and child health. So this was known as the Social Security Act. And it included Title V and it authorized grants to states to extend and improve services. The grants targeted maternal and child health, children with special needs, and child welfare services. This program is the longest federal state partnership to improve the health of all of the nation's mothers and children. Now, in the early 80s, there were 7 categorical programs that were consolidated into the block grant, into the single program of formula grants to states that were supported by a federal special projects authority. As I mentioned before, 85% of funding goes to the state block grant, and states and jurisdictions must match every $4 of federal Title V money that they receive by at least $3 of state and or local money or non-federal dollars. Many states overmatch, which results in more than $5 billion being available each year for maternal and child health programs at the state and local levels. State MCH health agencies, which are usually located within the state health department, apply annually for Title V funding. The legislation also requires states to submit an annual report and to complete a statewide comprehensive needs assessment every 5 years, and I'm sure many of you are familiar with that process. States have flexibility in how Title V funds are used to support a wide range of activities that address state and national needs. This slide shows the classic MCH pyramid of services. Title V plays a critical gap-filling role in funding individually delivered direct and enabling services for those who are uninsured or inadequately insured. This includes services that are not covered or fully reimbursed by available insurance. So things such as well child visits or immunizations. The full impact of Title V includes efforts to promote the access and quality of public health services and systems, which reach a much larger share of the population. In 2019, an estimated 92% of pregnant women, 98% of infants, and 60% of children nationwide were served by or benefited from a Title V supported service. So at the heart of the performance measurement framework of 15 performance measures, states select one in each of the 5 domains that you can see here. So we've got women's and maternal health, perinatal and infant health, child health, adolescent health, and children with special health care needs. We also have an optional cross-cutting system building domain. And really these measures are meant to feed into longer-term outcomes of morbidity and mortality. And based on state activities, states can develop their own state performance measurement. The needs assessment that is conducted is meant to identify priority needs, especially in some of these areas. We also have the Title V information system, and this allows you to look. I've provided this example here of performance measures in a given state. I've picked New Mexico because in spirit, that's where we should be right now. And we will get there next year. It's only been a couple years trying to get there. But this is an example of what the TVIS looks like for National Performance Measure number 1 for single women with a past year preventive medical visit. And so it allows you to look at state data and what the improvement targets are. This links to the federally available data or the FAD. And through this website, you can also review a state's full application and narrative, as well as an action plan. So we have state snapshots on here. If you all haven't seen the federally available data document before, I encourage you to look at it. It's great. It includes detailed information about all of the measures, the performance and outcome measures, as well as provides the data by certain stratifiers, as well as accompanied SAS code. And this is updated technically annually, but more than annually, a couple of times throughout the year. So it's really great for things such as figuring out the coding for measures like severe and maternal morbidity. We try to keep all of that current with SAS code that you can use directly in your own work. All right, back to North Carolina. So we went to the mountains and then we full circled back out to the beach. So this is the coast of the Outer Banks. This photo was actually just taken a couple weeks ago. This is in Corolla, North Carolina. For any others who might be from North Carolina, if it's pronounced Corolla like the car, then my apologies, but I'm pretty sure it's Corolla. This is close to where the wild horses are. In the many years that I've gone here, I have yet to see a wild horse. The horses are generally further out where the cars can't drive, but anyway, I thought this was a beautiful photo. And I really hope that you all were able to get a change of scenery in your lives this year, the way that we were. I think that was one of our goals, to keep our family happy and sane, was to try to change up the scenery safely when we could. All right, back to MCHB programs. So now I'm going to talk a little bit about the home visiting programs. So in 2010, the president signed the Affordable Care Act, which created the first nationwide maternal, infant, and early childhood home visiting program. Federal funds were allocated to states, tribal organizations, and nonprofit organizations to support evidence-based home visiting service. Since 2010, $1.5 billion has been provided, it's probably higher than that now, to states over 5 years, with an option for reauthorization, and funding has since been extended beyond that time. HRSA administers the Federal Home Visiting Program in partnership with the Administration for Children and Families, or ACF, and oversees grants to states, territories, and tribal entities to develop and implement home visiting programs. So you'll see I've provided some information here. We provide grants to 56 states, territories, and eligible nonprofit entities. We have 19 tribal organizations, and they're focusing on at-risk communities, serving pregnant women, families, and children from birth to kindergarten entry. Based on the most recent data, we've served over 140,000 parents and children and completed more than 925,000 home visits. Last I checked, there were 18 evidence-based models. And we also, through the legislation, the home visiting program is required that grantees demonstrate improvement in at least 4 of the benchmark areas. So I've identified each of those 6 benchmark areas here. And within these benchmarks, we have different measures that are used to assess sort of improvement over time. So I've also provided a web link here for more information about the home visiting program. Moving on to the Healthy Start program. The Healthy Start program is community-based. It links women to health and social services in an effort to improve perinatal outcomes and reduce disparities. Since our program's creation in 1991, we've grown from a demonstration project in 15 communities to 101 Healthy Start projects in 34 states, Washington, D.C., and Puerto Rico. There's close collaboration with local, state, regional, and national partners, and this really is key to the program's success. They are evolving to meet new needs with new efforts focused on father-partner engagement and reducing maternal mortality. Last year, we completed a evaluation of the National Healthy Start program, where we used a variety of linked data sources. We had vital records data, program data, as well as PRAMS data that was used to assess the impact of the program. There's more information about that on the website and some of our findings that we're in the process of writing up. And we also presented this information at last year's City Match conference. If anybody's interested in knowing more about that evaluation, please send me a message and I'd be happy to share. Now moving on to some of our maternal health programs. So many of you may be familiar with the AIM program, or the Alliance for Innovation on Maternal Health. Here, this map shows how many states have been enrolled in AIM, and these numbers are as of April 2021. So there are 21 states plus the District of Columbia that have enrolled in AIM. And within these states, we have approximately 1,900 birthing facilities participating in bundle implementation. AIM is funded through our SPRANS Title V funds, and AIM is a national data-driven maternal safety and quality improvement initiative that works with state-based teams to engage hospitals and health systems in improving maternal outcomes. The hospitals in these participating states may choose to align with AIM in order to access maternal safety bundles, which are designed to identify appropriate and timely responses that healthcare teams can take in response to maternal complications. And really our goal with this program is to eliminate preventable maternal mortality and severe maternal morbidity across the US. Through AIM, we're also able to address emerging issues impacting maternal health outcomes. For example, there is a safety bundle as it relates to opioid use during pregnancy, and a few others that I'll acknowledge on this slide. So here is a list of some of the maternal safety bundles. So for those who aren't familiar with a bundle is comprised of 10 to 13 best practices organized into 4 domains, which you'll see as on this example on the right-hand side: readiness, recognition and prevention response, and reporting and systems learning. The bundles are intended to ensure that relevant healthcare organizations are prepared for maternal events, understand the unique risks for such events, and develop systems for early warning signs, and universally implement a given protocol across providers in response to an event. So after a negative maternal event has occurred, staff conduct a formal and non-judgmental debrief to identify actions that contributed to the outcome. So I've listed here the core maternal safety bundles that are acknowledged at the top. So we have 4 core bundles. We have 2 currently in development. And then we have at least 6, if not 7, because the postpartum basics, there's 2 pieces to that of supporting bundles. So you'll see they cover a wide range of topics that are really important as it relates to maternal health and safety. Moving on to the AIM Community Care Initiative, it's one of the Bureau's newer maternal health investments. The purpose of this initiative is to support the development and implementation of non-hospital focused bundles within community-based organizations and outpatient clinical settings across the U.S. And really, it's building upon the foundational work of the larger AIM program by addressing preventable maternal mortality and morbidity among pregnant and postpartum women, except it's focused outside of the hospital and other birthing facility settings. Specifically, funding for this cooperative agreement supports the recipient's ability to conduct 3 core activities, including convening a maternal safety work group, facilitating national implementation and adoption of 2 existing non-hospital focused maternal safety bundles. So examples of those would be the postpartum care ones, and collecting and analyzing data, structured process outcome data, and that's used to drive continuous improvement in the implementation of non-hospital focused maternal safety bundles through a CQI framework. We also have the Supporting Maternal Health Innovation Program. This was awarded to the University of North Carolina at Chapel Hill, and it's a 5-year project period through 2024, and they've created a resource center, which they refer to as MLIC, or the Maternal Health Learning and Innovation Center. And the purpose of this center is to provide capacity building assistance to state maternal health innovation and Our Moms program recipients to implement innovative and evidence-informed strategies, and establish a resource center to provide national guidance to HRSA award recipients, states, and key stakeholders in improving maternal health. There's only 2 more. The State Maternal Health Innovation Program. This is really an interesting program. The goal here is to improve maternal health outcomes in the U.S. by catalyzing multidisciplinary collaboration, collecting and analyzing maternal data, and promoting and executing innovation in maternal health service delivery to advance evidence-informed strategies that achieve a measurable impact. Currently, 9 states who receive funding through the State Maternal Health Innovation Program. They began their work in 2019. And what's unique about this is that these are innovation awards. So each state has identified specific activities that are most relevant to the needs in their state. And then finally, we have another program called the Screening and Treatment of Maternal Depression and Related Behavioral Disorders Program. You'll see here the states that received funding for this, or not necessarily states, but communities within these 7 areas. And the purpose of this program is to expand healthcare providers' capacity to screen, assess, treat, and refer pregnant and postpartum women for maternal depression and related behavioral disorders, such as anxiety and substance misuse, including in rural and medically underserved areas. The program also aims to increase access to affordable, culturally and linguistically appropriate treatment and recovery support services. So again, I've provided links to all of these programs if you want to learn more about them. We have several, and again, this is not comprehensive. We have many other programs in our maternal health portfolio. So this is our last poll. And I want everybody to sort of think about what you're most looking forward to learning about during the course. And if you can type your message into the chat, that would be great, so that we can sort of see what it is you're hoping to learn and make sure we meet your needs the best that we can. Hopefully you're all still with us. Thank you guys for your input. Great, so we have social determinants of health, evaluation, analytic methods, QI, program evaluation, a lot of evaluation, data communication. Looks like some little bit of every part of our agenda, so that's great. Awesome, PPOR, great. And again, if there's something else that you're hoping to learn that may not be covered in the course, I encourage you to look at some of our past training resources as well, and Ashley will tell you where you can find all of that information. All right, so some final thoughts. So I just want to kind of think about what is the purpose as epidemiologists of what it is that we're doing. And really, we're focused on applied epidemiology. Our purpose is really health optimization, disease reduction, and we don't want to get too distracted by techniques. But again, it's really important to think about the purpose of what you're doing. Methods are really tools that are useful only to the extent that they serve that purpose. And so thinking about sort of what kind of statistics that we look at descriptive statistics. That tells us who, what, when, and where. It describes the distribution of disease patterns. And then we have multivariable statistics, which I know we will cover some of that in the course this year, that focuses on the why and how. It allows us to look at determinants or causal effects for factors, whether we're looking at interventions or associations, and we can assess contributors to trends and disparities. And sometimes simple statistics are powerful. And I just want to remind us of that, to not get too hung up in some of these fancy techniques out there. And it's important to ask the right question. So again, think through, when you're thinking about questions, think through it before jumping in and just running the data. Think about what's the purpose? So what? What is it that you're trying to answer? Do you have requests or buy-in from who will use the information? Has it been done before? Is it likely to be different than findings from previous studies? Is it etiologic? Is it risk factor focused? Versus quantifying the population contribution or potential impact in intervention. Do you have a dissemination and translation plan? And these are just things to think about when you are thinking about what question it is that you're trying to answer. So with that, I'm going to leave you with a final photo. This is where I'm hoping to be in November if all things goes well. This is a picture of Costa Rica, which is one of my favorite places in the world that I've been, and I haven't been to a ton of places, but my family was supposed to go last year and it was canceled. And if all goes well and my kids are able to get vaccinated, we're hoping to be there later this year. And I hope you all too can find ways to just change your scenery a little bit. I think it's really important coming off of what I know has been a challenging year for everybody. I want to give props to New Mexico again, because we will get there. This is what it hopefully will look like. It might look a little different next time. I don't know. And I want to thank you all for being with us again for this course. I know it's virtual. It's different than past training, but I promise you, we have a great lineup of faculty, guest speakers. I think one of the things that virtual courses really afford us is the opportunity to access people that we may not otherwise be able to access, who can't always join us in person. So I truly believe that that's a strength of having the virtual course. And so I have provided my contact information here. Please reach out anytime with questions, thoughts. If you want to meet and talk about careers in federal government, pretty much anything, reach out. And here's information about our agency. And I just want to thank you all for your time and attention today.
Any questions for Catherine as we wrap up? All right, wonderful. Well, you all have her contact info if you have something that you want to send directly to her. So by way of wrapping up, yeah, thank you, Dr. Vladutu. It was great to hear from you. Thank you all of you for joining and participating. I want to echo again what Catherine said earlier. You should feel really good about yourselves for being here, because there were a lot of applicants to this course, and the application review was difficult. So you all are a great group. I hope that you have a chance to network with each other, because there's really a lot of experience and expertise among everybody that's here. So one of the strengths of this training course is hopefully, it is when we meet in person, we have to make it that way since we're meeting virtually. It's the opportunity to build a larger network of people who are doing things similar to what you're doing in other places, right? It's such a good resource to have other people who have seen some of these issues that you're running into before, or may have seen them from a different perspective, or somebody that you can talk to about things that don't know the politics of your organization and all of those things, right? That you can just talk to about generally. So please make an effort to engage during these sessions, because that's one of the limitations of this virtual format, is it's harder to make those connections and networks. So that's on all of us really, to make that happen over these next few weeks. We are going to try to take advantage of the opportunities that a virtual course presents that we don't have when we're together in person, right? So as we've talked about before, we're bringing in some folks that just have so much experience and expertise that would not normally be able to join us. I'm really excited about that. I'm really excited about hearing from our regular faculty and the additional folks that we're going to have. So to close out, just a few things to be on the lookout for. You should hear from Ashley later this week with an invitation to the Teams page. And there's also a video that she'll send out if you aren't familiar with using Teams, or can't, you get the link, but it's not pulling up right, or whatever. There's always things that don't go the way that they're supposed to go. So be on the lookout for those things. We want to make sure that we get all the troubleshooting done right before the training course officially starts in a couple of weeks. So please, when you get that email, try to get logged in, make sure that you can access everything. And if you can't, reach out to Ashley or myself, and we will try to get you get everything working the way that it should. And you will hear more from me next week, a week from today. So I hope that you will all be able to join that. And I look forward to talking to you more. Anything else, Ashley, before we close out?
No, I think you covered it. You'll have a few emails from me about the recording from today, slide deck, and evaluation, faculty introduction videos, and then team access. So we hope that it's a smooth onboarding for that platform, and there's some great functions in Teams too, so you can utilize the chat and video conference with your colleagues, and we hope you utilize that for networking, as we mentioned. So you'll be hearing more from me, and again, thank you, Catherine, and we will see you all in a week.
Bye, everybody. Thank you.
Thank you.